So my name is Claire Roddie. I'm a consultant hematologist at University College Hospital, London, and I've been attending EHA talking about our CD19 CAR T-cells for adult acute lymphoblastic leukemia. I think we all recognise that relapse and refractory adult ALL is an unmet need, and at the moment there aren't any therapies available that can give long responses. And that's why CAR T-cells are compelling in this regard, because in the pediatric and young adult setting, there's huge data sets to support that long-term remissions with this therapy. But we recognize from the pediatric and young adult setting that there's significant toxicity associated with CD19 CAR-Ts. And so in designing this study of ALLCAR19, we really had toxicity minimization at the very heart of the study. The reason is because we're trying to apply this therapy to adults with acute lymphoblastic leukemia, and we know these patients are very vulnerable and often have lots of comorbidities and have been through lots of previous treatment. So the object was really to develop a new CAR, and we're using a CAR called the CAR or AUTO1 in this context. And it's different from other CD19 CARs in that it binds to CD19 in a different way. It has a different kinetic. It has a lower affinity for CD19 and comes off target, and it behaves in a more physiologic way. So we believe that this has potential benefits in the sense that the CAR T doesn't secrete as much per cell in terms of cytokines, and we feel that this potentially benefits the patient, and particularly a vulnerable patient, as it makes them less likely to experience severe cytokine release syndrome. That's the hypothesis. So we've taken this novel CAR and we've generated a study or run a study of 19 adult patients with acute relapsed and refractory acute lymphoblastic leukemia. And what we've done is we've made autologous CAR T-cells for these patients. They're second generation CARs, 4-1BB Zeta endodomain. And the patients are recruited on study, they're leukapheresed, and then they undergo bridging therapy to hold them until they are at the point of being able to be admitted for CAR T-cell therapy. Now, the most important caveat to this study is it's all about minimizing toxicity risk. So we have two design features in the study to help with that. The first is that we titrate the starting dose of CAR T-cells to the patient's disease burden, because we know that high burden disease is associated with more significant toxicity. So if you have more than 20% blasts in your bone marrow at the outset, you will receive a smaller starting dose of CAR T-cells. The second design feature to minimize toxicity is that the dose of CAR T-cells is split between day 0 and day 9. And if patients develop toxicity after the first dose of cells, they will not then receive a second dose of CAR T. So that helps us to manage any potentially toxicity associated with this therapy. So what we found to date, so as I say, we've recruited 19 adult patients with relapsed and refractory disease. The types of patients we're getting on study, the median age is 43 years. There was 32% of the patients had the poor prognosis Philadelphia positive disease. They've been heavily pretreated. So they'd had a median of 3 prior lines of treatment. And a significant number, 47%, had prior exposure to inotuzumab and 26% to blinatumomab, and 63% had a prior allogeneic transplant. And when they came to us, there was a significant number of patients who had high burden disease. So 42% of patients had more than 50% blast in their bone marrow. And this is a population by definition at high risk of CRS and neurotoxicity from CAR T-cells. And so the other thing that we looked at in this study was about feasibility of making CAR T-cells for patients. We're an academic center. This was a phase 1 study, and it was all about trying to scale the manufacture of CAR T-cells to meet the number of patients that we needed to treat. So we did also explore a semi-automated closed manufacturing system called the Clinimax Prodigy, and we utilized that for a significant number of the products in our patient cohort. Now, in terms of the outcomes, well, looking at the products that we made, certainly the Clinimax Prodigy created a good product for us. So a significant proportion of the cells were memory T cells, which we know are associated with better persistence in the patient. And when we looked at the patients, we noted that the CAR T cells were able to be determined in the bloodstream of patients beyond 12 months in a proportion of treated patients. So these are CAR T cells that persist, and that seems to be important for ALL particularly, where recognize that persistence is associated with better long-term outcomes. Now, one of our original hypotheses was that because this is sort of a low affinity bind, does it mean that we get less from the CAR T? And that seems to have been clinically experienced to date, because in this patient population, we didn't see any cases of grade 3 or more cytokine release syndrome. And cytokine release, as we know, is very common in ALL. We did see some instances of lower grade CRS, that's grade 2, was reported in 7 of our 19 patients. But those patients were they were predictable in advance, in the sense that they all had high burden BALL, and they were managed very swiftly for this with tocilizumab, which was used in 32% of our patients. ICANS, or neurotoxicity, is another significant complication of CAR T therapy, and it can be quite difficult to manage, as is reported in other clinical studies, and can be of quite long duration. We did see neurotoxicity on this study in 4 out of our 19 treated patients. Grade 2, and a grade 2 event was reported in 1 patient, and a grade 3 event was reported in 3 patients. But I think the point to make here is that the grade 3 events responded very, very quickly to steroid treatment. So in the sense, 2 out of those 3 patients had resolution to grade 1 ICANS within 24 hours of steroids, and the latter patient in 72 hours. So that's really quick resolution of this side effect. And again, it was very clear who those patients were going to be in advance. All of them had heavy burden disease, and actually all of those cases were preceded by CRS. So if you were talking about a mitigation strategy to reduce the risk, you could see how those would be patients that you would watch more closely, and you would perhaps intervene early. So those were the sort of the toxicity events noted on the study. And then I guess the most important thing in what patients really want to know is whether or not it works. And in our cohort, we find that 11 out of the 19 treated patients, that's 58%, are currently disease-free, and that's with a median of 12 months. So the important thing, I guess, to note about this is the fact that they didn't go on to have a consolidative allogeneic transplant. So we've got patients who've reached the 12-month mark and beyond, and are still in remission, with effectively the CAR as their only treatment. So we feel that this really could represent a standalone treatment for adult ALL, and without the need for any consolidation with any other therapy. And I suppose, to conclude, really, we are very heartened by the data, because I think you can't emphasize enough how difficult this situation is to manage clinically, and we really don't have many tools in the arsenal to optimally manage relapsed ALL in the adult setting safely. And so this is a really, this does offer a lot of potential, and it does seem to be quite sort of low risk in terms of the safety profile that we've seen to date. CAR expands in the blood, it engrafts, and it seems to persist. And in terms of efficacy, we're getting really good responses at 1 month, 84% of patients achieving MRD negative complete response, and it seems to be durable as well. And 58% of patients, as I say, are disease-free at a median of 12 months. So this data set, we're hoping to take this to a phase 2 study, and just look at a bigger population of patients, and hope that we can sort of, confirm the findings of this early phase 1, and hopefully just, come up with a new treatment for really, a very difficult to manage clinical situation of relapsed ALL.